Thank you. So my talk today is MRI biopsy, making sure you hit your target. So the objectives of the talk today are to review the indications and contraindications for breast biopsy under MRI guidance. I'm going to review the overall basic technique and supplies that are needed for a successful biopsy. I'm going to review reasons for cancellation and other problematic factors in breast MRI procedures and provide some strategies to optimize success using real-life cases, and finally discuss, very importantly, post-biopsy lesion management with meticulous radiology pathology correlation. So MRI-guided breast procedures are safe and increasingly routine method for evaluating suspicious findings on MRI. The ACR actually requires any facility seeking breast MRI accreditation to either be able to perform their own MRI-guided procedures or have a referral center. But MRI-guided procedures can be challenging. They actually have relatively high cancellation rates, ranging from 8 to 17%. Therefore, MRI-guided procedures require skilled, experienced radiologists as well as skilled supporting technologists who are really familiar with the MRI-guided procedures, the techniques, and can offer some key problem-solving strategies. So what are the indications? So the indication for an MRI-guided breast biopsy is going to be any suspicious finding, so BI-RADS 4 or 5, that's detected on breast MRI, but you don't have a definite correlate on ultrasound or mammography. So findings that usually don't have a definitive correlate on ultrasound and mammography include foci, non-mass enhancement, or small masses less than 1 centimeter. Actually, at our institution, we don't really send these things for targeted ultrasound because the yield is low and we feel like it delays the care a little bit. So contraindications include contraindications for a regular breast MRI. This includes claustrophobia. If you have an MRI incompatible and metallic or magnetic device, such as a cardiac device or a stimulator. And finally, if the patient has any contrast-related issues, such as renal impairment or an allergy to gadolinium-based contrast. So I always tell my residents and fellows that the pre-procedural steps are as important, if not more important, than the procedure itself. Pre-procedural planning for any breast biopsy is important, but I feel that it is particularly important for breast MRI. And therefore, it's important to carefully review your diagnostic breast MRI image. You want to know what quadrant you're in, what's the clock face, what's the depth, the distance from the nipple and the skin. And that's because patients can be positioned differently in the MRI magnet after the patient is in the grid and with compression. And so you want to be able to confirm your landmarks and recognize where you are on the diagnostic MRI compared to your positioning in the breast biopsy. It's also important to talk to the patient during the consent. Explain to the patient the procedure, and then also let them know that sometimes the target may not be reproducible, say it's background parenchymal enhancement, which may result in cancellation of the procedure. And if the patient is prepared for that, they understand the next steps. And other times, the target may be inaccessible or not feasible for biopsy. In particular, if patients have implants, it's important to talk to them about the risk of implant rupture, and this should be actually included on the consent form. So everyone has different equipment, and so it's important to be accustomed to your own equipment and just be comfortable with it. So at our institution, some of us use a scalpel. I do, others in the group don't, so that's up to you. We have a needle guide, or your grid square. You have a plastic introducer sheath, which is where your introducer stylet will go in, and then it gets replaced by an obturator. We use a 9-gauge MRI-compatible vacuum-assisted device, and then you're going to have 2 types of those. You'll have a petite or a standard. The petite is a 12-millimeter bowl, and your standard is a 20-millimeter bowl, so I will go over that in a few slides and the importance of using that in targeting your lesion. Of course, you have a breast coil and your breast compression device. We use lidocaine 1% without epinephrine. I know many places use with epinephrine and bicarbonate. We had an epinephrine shortage during COVID, transitioned to lidocaine 1%, and have not had any issues after that. If there is an allergy, we use the others in the cane family, including procaine. So similarly, it's important to be familiar with your MRI-guided breast biopsy protocol. I'm happy to share our protocol after this talk because it does vary from institution to institution. But the goal is to have a breast biopsy protocol where your target is reproducible, yet it's a fast protocol. So I'll quickly go over what we use. We do a sagittal and axial pre-contrast T1 weighted fat suppressed image, and we do that in order to ensure that the grid is covering your target. Then we use a sagittal post-contrast image, and that's to ensure that you see your target. Then we go to axial post-contrast images, and that's to locate the target in relation to the skin so you know the depth to go into, and then sagittal and axial post-biopsy images so that you see your post-biopsy hematoma and ensure that the target was sampled appropriately. Some people in our group, I don't personally do this, but they do an axial T1 non-fat suppressed image as an optional clip image. So after you place the clip, you can take this image to make certain that your clip has deployed. So now I'll go over some basic procedural steps of the MRI biopsy. Positioning is incredibly important. You want to make sure that your patient is positioned in the grid in a prone position, and you have a fiducial marker to allow you to target your finding appropriately. So your lesion coordinates can either be calculated and targeted either manually, as we do, or using a dedicated biopsy software. So again, just be familiar with what your institution does. So when you review the manual targeting, you use an MRI biopsy worksheet. I have an example of ours here. And I always say that the most important thing when you look at your worksheet is to make sure you have the correct worksheet. Make sure it's right or left, and medial and lateral, because if you use the wrong worksheet, you're going to be in a different target. The fiducial is denoted by the purple circle, and then you have the X that is your biopsy target, and you can see that there is an image view that will triangulate to the patient view. And then on the right, you see that the obturator is in place, and that's going to be your depth from the skin to the lesion. So after you have targeted your finding, you want to clean and anesthetize the skin and the deeper tissue. You place your device and obturator to the lesion depth as you've triangulated on your axial view, and then you sample by manually rotating the vacuum device. You place the clip, and it's always important to obtain a post-biopsy mammogram. However, you can plus minus use a clip sequence to confirm that as well. So now that I've gone over the equipment that's needed and some basic procedural steps, I'm going to review some challenging cases, ranging from lesion non-visualization to the importance of clip correlation. So let's start with challenge 1, lesion non-visualization due to compression or just overall non-visualization. And I know this has happened to all of us who've done an MRI biopsy. You get to the scanner and you just can't find the lesion again. So here are some tips. This is an example. This is a screening MRI in a 50-year-old woman. She has a family history of breast cancer, and there's a focal area of NMA in the breast. You can see at time of biopsy, which is the middle picture, it's not present. So you recommend a 6-month follow-up MRI, and you can see that there's a slight increase in the focal area of NME. MRI-guided biopsy was performed, and this ends up being DCIS. So how could we have problem-solved this case at the time of biopsy? So in retrospect, this finding was likely not present due to overcompression. So what happens when the breast is overcompressed, there's decreased vascularity to the lesion. So some tips to prevent this is that you can gently ask the tech to gently loosen the breast, but keeping everything else in place so that you can still do a biopsy. I also ask the technologist to do subtraction imaging on the scanner so I can see if the finding is enhancing. So lesion non-visualization at biopsy is the most common reason for cancellation of an MR biopsy, and it ranges from 8 to 13%. A large study done in 2011 of over 900 patients found an 8% cancellation rate due to non-visualization. So what is the subsequent malignancy rate? In that study, it was 1 out of 61, so a 2% malignancy rate. And why do we not see these lesions on the day of biopsy? Well, reasons can include hormonal influences, background parenchymal enhancement, or overcompression. And as I just mentioned, if overcompression is considered, release the compression grid slightly, keeping everything else in place so that you are able to do the biopsy or perform subtraction imaging. So despite the low malignancy rate, it ranges from 0 to 10% in the literature, it's important to repeat a breast MRI in 3 to 6 months, depending on the suspicion of the finding, just to have a follow-up. So this is a quick review of the literature, the rates of malignancy and cancellation rates in MR-guided biopsy. You can see that the number of biopsy ranges from 83 to 911, with the cancellation rate of 8 to 13%. So this is quite a number of patients. The overall malignancy rate, so 2 of the studies showed a subsequent malignancy rate ranging from 2 to 10%. So small, but still requires a follow-up. This is our second challenging case, breast implants. So this is a high-risk screening MRI, focal area of NME, in a 39-year-old woman with a family history. So you can see on day of biopsy, the breast implant is pushed out of the way, but there's actually no abnormal enhancement. This was placed in short interval follow-up, and there's no evidence of disease to date. But the point of this image is actually to demonstrate how we move the implant out of the way. And this is where it's incredibly important to work with your MRI technologists and make sure your MRI technologists are aware of breast MRI procedures. And so they push the breast implant out of the way, allowing for the grid to have the most amount of tissue space. And this will allow you to do a safe biopsy as well. So some tips for breast implants: again, inform the patient that there is a risk of rupture at the time of consent, and I actually write it in as a separate line item. Positioning is important. The implants must be displaced posteriorly to increase tissue between the target and the implant. And if the lesion is adjacent to the implant, which can happen, don't panic, place the needle anterior to the target lesion and sample away from the implant. So sometimes I don't even rotate the device, I just leave it in that position and take tissue sampling to avoid implant rupture. Okay, our challenging case number 3, difficult positioning. So you're reviewing your imaging and you see it's a posterior lesion. These are tough, particularly posterior medial lesions, which I'll talk about separately. So this is a screening MRI with focal NME in the posterior lateral breast. And at the time of biopsy, you can see the far posterior lesion that if you put your introducer in, you're going to hit the pectoralis muscle. So this biopsy was actually canceled because of the posterior lesion, pectoralis muscle, and in fact, the radiologist thought there might be some decreased prominence of the finding. So they reviewed all of the prior imaging and felt that it was waxing and waning and likely BPE, put it in a 6-month follow-up, and it was no evidence of disease to date. However, if you have a finding that is very suspicious, really posterior, and you're unable to get it, there are other ways. One is you can place a wire, an MRI-compatible wire for surgical excision, or at our institution, we place a clip for subsequent localization. We do seed localization, but those are 2 tips to help you excise a finding that's suspicious but may not be technically feasible to biopsy. Other strategies to help you access posterior lesions. Use padding. So this is a nice example from a radiographics article. If you use padding, rolled blankets or towels, you can support the patient in a prone oblique position, allowing for the patient's biopsy grid to allow a biopsy of the finding. So you want to roll the patient away to bring the lesion into the biopsy window. Sometimes you can bring the patient's arm down, that might be helpful, or raise the grid to access more posterior lesions. So now another difficult location, the medial lesion, and this is the posterior medial one, which I find to be the most challenging. You have to use a lateral approach in these cases, and that's because the breast coil design precludes access to the most posterior medial lesion, so this can be challenging. In this case, we decided to do an MRI-guided wire placement for surgical excision, and you can see the last image. You can see that the arrow points to the target, which is posterior to the wire. So what we had told the surgeon is, please go posterior to the wire towards the chest wall. So we communicate with the surgeon and tell them this is the direction you should be taking the tissue. But despite of that, the patient had a big fatty breast and the wire actually internalized, so the pathology on excision was benign breast tissue. We reviewed this at our radiology pathology conference, and the decision was that we could place her in 6-month follow-up. However, the patient returned at 6 months with a palpable finding in this location. So at 2 o'clock, she has a palpable irregular hypoechoic mass that correlates with our initial MRI. So we did a ultrasound-guided biopsy, and this was an invasive ductal carcinoma. So really the teaching point here is that despite this was appropriately managed with surgical and radiologic management, very posterior and medial lesions can be challenging to sample. Here's another example of a difficult medial lesion, and so the medial approach was not possible in this patient. She has a 6-millimeter left breast irregular mass on her screening MRI. She's a 30-year-old with a BRCA1 mutation. At the time of biopsy, we took a lateral approach and got benign breast tissue, non-mass-forming lesion. So this is discordant. I'm going to talk a little bit about concordance. If you have a mass on MRI and you're confident that it's a mass, you should have a mass-forming lesion on pathology. So this underwent a medial approach MRI-guided wire localization and ended up being a fibroadenoma. Other considerations, you can do needle angulation, and very rarely we do a freehand technique where we're doing serial interval imaging to ensure that we're going in the right direction, because if you freehand it, you want to make sure you're not bypassing the lesion in the other view. So some tips for posterior and medial lesion. Again, you can roll the patient obliquely in the ipsilateral side, and if you cannot get it from the medial approach, you're going to have to take a lateral medial approach. So our next challenge case is superficial lesions. So superficial lesions can be very challenging because you don't want to biopsy the skin. And so this is a 42-year-old woman with a history of left breast cancer, and she has a new right central inner breast mass at a superficial depth. And so at the time of biopsy, you have to decide, are you going to use a standard or a petite needle? And I'll show you how you can determine that. We used a petite needle. You can see that the biopsy device goes to the enhancing mass. Let me see if this works here. Yep, biopsy device and the enhancing mass. This is an invasive ductal carcinoma. So how did I determine that? So you have a standard needle and a petite needle. Both are 9-gauge needles. The aperture of a standard needle, or the bowl size, is 20 millimeters. So if you position your lesion in the center of the bowl, you need to have at least 18 millimeters past the center of the lesion to safely do the biopsy. That's 10 millimeters, so half of the aperture, plus the dead space of 8 millimeters. If you have a petite needle, your aperture or your bowl is 12 millimeters. Half of that is 6, so if you center your lesion in the middle of the bowl, it's 6 plus the dead space of 4 millimeters. 6 plus 4 is 10. So you need to have 10 millimeters past the center of the lesion to safely do that. So say that you can't do that. Say that you're very superficial. A couple of things I do. So one is that you can see down here, I make a 2-millimeter bowl and a 12-millimeter bowl. I ask the technologist, please draw a line for me and place the center of the bowl, or this pretend bowl, in the lesion. And that helps me determine if I'm going to accidentally biopsy the skin or not. So that's one tip I use. The other thing is that you don't necessarily need to have your lesion in the center of the bowl. You can bury your bowl a little deeper, and rather in the center, to allow for successful sampling without cutting the skin. So this is where pre-procedural and procedural planning is important, and recognize as long as the lesion is within the bowl, you will get a sample. So now you've tried everything you can, but you still can't get the finding. But some findings are suspicious and need to be sampled. This is a 63-year-old woman with bloody nipple discharge and a negative mammogram and ultrasound. A problem-solving MRI was done, and you can see that there's subtle linear subareolar NME. This was too superficial and too difficult because her nipple areolar complex is actually over here. The nipple is not in profile. So it's too superficial for a biopsy, even with a petite needle. So what we did is we placed a clip. So you place everything into the breast as though you were going to do a biopsy, but rather than doing the actual biopsy, you place the clip, and then you can see here, this is our post-clip sequences that shows the susceptibility artifact of the clip. And then this was localized for excision and is a papilloma. So what if you have bilateral lesions? As we know, breast MRI lesions rely on vascularity, and once you start that biopsy, the time is ticking away because you don't want the findings to wash out. So if you have bilateral lesions, and you're lucky enough to have another radiologist, which we know in breast imaging is a little challenging now. So if you have another radiologist available or a fellow or a resident, you can do bilateral simultaneous biopsies, So this is a 57-year-old woman. She has a family history of ADH. She has bilateral findings, linear enemy on the right, an irregular mass on the left. The pathology is bilateral epithelial hyperplasia. Another technical challenge of bilateral lesions is that you can only go from bilateral-lateral approach. You can't go from one lateral and one medial. And so if you have a very medial lesion here, this is a left medial mass, and a very lateral lesion, it is going to be very challenging to do those simultaneously. In this case, we actually used our non-contrast images to help us. Pre-procedural planning is important. Look at your non-contrast imaging. If you can find the findings safely, of course you want to be able to see your finding well, you can use non-contrast imaging to help target the lesion, and that's what we did in this case. It was actually serially done, starting off with the right lateral mass and then the left medial mass. These were both benign. So some other tips for bilateral lesions. Biopsies will be needed to be performed simultaneously if possible. Spend time planning your approach. Consider non-contrast sequences. You can only do one approach laterally to medially, so it's always helpful to set up your biopsy equipment ahead of time and make sure your lidocaine can be drawn, et cetera, so that you are ready to go for that second biopsy. But also remember that there is a lidocaine maximum dose for patients, and so if you have more than 2 biopsies for a patient, calculate that lidocaine dose, and they may need to come back on a different day. So the next challenging concept is rad path correlation. This is very important, and I'll go over why rad path for MRI is more difficult than mammo and ultrasound. So this is a diagnostic MRI. You can see that there's a spiculated mass at 6 o'clock in this high-risk patient with a BRCA2 carrier mutation. You can see that on day of MRI biopsy, here's the obturator and there is the mass, so it is a little bit distant from the finding. This is the area on the sagittal view, and this is your obturator, and you can see that it's a little bit distal from it, or distant from it. This is where post-biopsy imaging is very helpful. You can see this area of hematoma, but however, the finding was not appropriately biopsied. The MR biopsy revealed usual ductal hyperplasia, and this was thought to be discordant. And that's because you had a spiculated mass on your original imaging, and you did not get a mass-forming lesion on pathology. So re-review of the imaging suggested that this was undersampled, and then the decision was made to excise the clip. It was an invasive ductal carcinoma. So why is this more challenging compared to mammo and ultrasound? I always say on mammo and ultrasound, you know what your finding is. You have calcifications, you can see it in your specimen radiograph. You have an ultrasound with real-time imaging of a mass, you get a fibroadenoma. But challenging for MRI is because you have non-mass enhancement. It's harder to make that rad path correlation. And the false negative rates can be up to 4%, with discordant rates up to 36% in the literature. And that's why you need to have scrupulous rad path correlation. If you biopsy a mass, expect a mass-forming lesion on pathology. What if you have a benign biopsy? I think practices are a little bit different, but again, careful rad path correlation to ensure your appropriate lesion sampling. I go through each image all over again when I get my pathology to ensure that I felt that the target was sampled. Evolving issues, if you have a benign concordant biopsy, do you need to follow it up? Institutions do it differently. Some suggest a 6-month follow-up MRI, and some studies demonstrate a low upgrade rate, and it's not needed. At our institution, I think it's predominantly if you have non-mass enhancement and just want to make sure that the finding doesn't change. What about for ultrasound? I didn't go over this in the talk, but if you do biopsy something, an ultrasound, should short interval MRI be recommended? Again, I think that depends on your clip location. Do you think that the clip matches the finding that was seen on MRI? And you have to make sure that when you do the follow-up, that the finding is either absent or decreased. And this is a nice example of this. Challenge 8, complications. 44-year-old woman, family history with a personal history of breast cancer on the left. Her screening MRI shows an irregular spiculated mass on the right. We called it NME. And at the time of biopsy, a large hematoma develops. The pathology is benign fibrosis, and management is a 6-month follow-up MRI. So on 6-month follow-up MRI, you can see that the finding is still present, and possibly there's the clip there. The area was thought to be an unchanged focal area of NME and was given a BI-RADS 3. The area is unchanged. It hasn't gotten smaller. It hasn't been biopsied appropriately. And unfortunately, like some of our patients, this happens. The area continued to grow at 4 years after the initial biopsy. So she didn't come back until 4 years later. You can see now the mass has increased in size. Repeat biopsy was recommended. This is a grade 1 IDC. And so although in retrospect this was thought to be unchanged, it really should have been smaller or given some evidence that it was biopsied appropriately. So complications, there's a low incidence of complications, 0 to 6%. Most commonly, it's a hematoma. Consider lidocaine with epinephrine. Hold compression. I always say ice is your best friend that day. It's really helpful. We lavage and suction the biopsy cavity. There's 2 ways to do this. One is manual aspiration, when you place the biopsy device back into the cavity and hit manual aspiration. We also use a syringe technique for smaller hematomas. Complications also include skin tearing for superficial lesions and infection. This is rare, but we do see it in lactating or pregnant patients. And so this is the hematoma evacuation using our syringe technique, where a syringe is placed at the stopcock. And this is when the patient is in the biopsy itself, and then we just suction out the hematoma. This is our last challenging case. This is the importance of mammo-MRI clip correlation. This is a 51-year-old woman with a history of DCIS. She has a small mass at 12 o'clock, as denoted by the orange circle. At the time of biopsy, we thought that the biopsy clip was in an appropriate position. This was epithelial hyperplasia and PASH, thought to be benign and concordant. However, the radiologist did put it in a 6-month follow-up. And you can see here at 6-month follow-up, the mass still persists and the clip is distant from the mass. So you have to remember, if something is biopsied, it should be either smaller or have a clip adjacent to it. And therefore, because the clip was inferior to the mass, a repeat MRI biopsy was performed, and the pathology here was invasive ductal carcinoma. So if the clip is not in accurate position and the finding isn't decreased on the subsequent imaging, have a low threshold to rebiopsy. Great, so thank you very much.